Professor Emeritus Lakshman Samaranayake of the University of Hong Kong is an internationally renowned clinical academic with expertise in clinical microbiology, research, and senior executive level administration. He passed out from the dental faculty of the University of Peradeniya with Bachelor of Dental Surgery in 1971. Then he obtained Doctor of Dental Surgery from the University of Glasgow in 1982. He served as a consultant clinical microbiologist in Scotland and subsequently joined the academia. Since then, working in 5 different transcontinental universities in the UK, Canada, Hong Kong, Australia, and UAE. Trained in dentistry and pathology, he is a recognized international opinion leader in pathology and infectious diseases. Professor Samaranayake is considered the foremost international authority on the oral microbiome. He has authored over 450 scientific communications, cited over 29,000 occasions. With the H index of 93, he is currently ranked as a top 2% scientist in a global survey by Stanford University, USA. He is the founding editor-in-chief of the Journal of Investigative and Clinical Dentistry. He is an author of seminal texts in clinical oral microbiology. Professor Samaranayake is currently the editor-in-chief of the International Dental Journal as well. He served over 12 years as the executive dean of the 2 major dental schools at the Universities of Hong Kong and Queensland, respectively. His leadership role for 10 years at the Hong Kong University led to the ranking of the faculty as the top dental school in the world from 2016, 2017, and 2018. A highly sought-after speaker, he has addressed professional bodies in over 40 countries and received numerous accolades for his research, including the coveted King James IV Professorship of the Royal College of Surgeons in Edinburgh. He has also received the Distinguished Scientist Award of IADR USA, which is the supreme research body in dentistry. Despite being a world-eminent academic, his love for his alma mater remains unchanged. He has made personal donations of over 3.5 million rupees to establish research awards at the University of Peradeniya.
Right, so thank you for listening to that. So I will stop sharing. Thank you. I just put this up so that because there's no compare in this meeting. Now I would like to share my for next 30 minutes my presentation on COVID, and I hope you can see this. Yeah. Okay, so I have been speaking on COVID and dentistry I have written about 16, 17 papers on this subject over the last 4 to 5 years. And it is a very vast subject, and COVID has impacted dentistry in so many different ways. So this is how I'm going to do my presentation. I will provide you with some historical aspects, and then go on to I will tell you a little bit about the past pandemics and dentistry, and how next the current pandemic and dentistry, how and what did we do, and how it has affected dentistry in many, many different ways. And then I'm going to look in the glass ball, as it were, and just spread it a little bit, few things about post-pandemic dentistry. Okay. So this is my outline of the presentation with the preamble, past, present, and future. Now, like to take you a step back. Some of you may recall in 2003, of course, I believe all of you will recall, that we had this, one of the premonitory signs of this pandemic type of infection, which is called severe acute respiratory syndrome, which is what we used to call SARS. And fortunately, it spread only to about 10 countries, although in Hong Kong, we had the brunt of it with almost 299 deaths. because the person with the initial infection, who was a doctor, realized he came from Guangzhou, which is an adjoining district, to get better treatment in Hong Kong. But nobody knew that it was a new disease caused by a coronavirus. So that was called the severe acute respiratory syndrome, or SARS pandemic. This happened in 2003. So at that time, the person who described the virus, Professor Malik Piris, and I was invited, wrote to the JADA about the pandemic and its effect on dentistry. Rather the epidemic, it was not a pandemic, thankfully. So we wrote in that last concluding remarks, the dental community cannot let down its guard and must be constantly aware of impending infectious threats in various guises, as well as recrudescence of disease that may challenge the current infection control regimes. And lo and behold, 16 years later, we got the current pandemic. And unfortunately, some of our predictions came true. Now, bring you fast forward into 2021, the editor of JADA, Tim Wright, asked me to write a keynote article in JADA last year, which appeared in the January issue of JADA, about the pandemic's past, present, and the future, and their impact on dental care. So most of the things which I am going to mention here is going to be related to that. So let's get on with it. Now, I'm sure all of you are sick of seeing this virus, which is a RNA virus, and a small strand of RNA virus, a small strand of RNA has revolutionized how we live and how we lived over the last 3-4 years. But just shows the power of the nature, and we can't overcome the power of nature. And this is actually seen in currently in China, where they're going to have zero COVID policy, which is not going to happen because it is going to spread. And we have to live with this virus, as I will show you in a moment. So the virus has, as you know, the spike glycoproteins, which attaches itself to the eukaryotic human cells. And we have almost all the cells in the human body has receptors to this spike glycoprotein. Particularly the throat and upper respiratory tract and the lower respiratory tract are very vulnerable. And as soon as the virus enters, when we inhale through the air, then it latches onto these cells in upper respiratory tract and spreads down into the lungs and cause lethal disease. And fortunately, due to the vaccines, we are spared of these deaths, almost 90 to 100% of the deaths. And the virus actually can just latches onto the only upper respiratory tract, which gives us common cold-like symptoms, which will last for about 1 week. Now, unfortunately, these viruses have, as I said, the force of nature cannot be stopped. And this was very elegantly expressed by Charles Darwin in his book on the origin of species, in regards to the evolution of living things. So he said, and I quote, "In the struggles for survival, the fittest win out at the expense of their rivals as they succeed in adapting themselves best to their environment." So we can see a living example in this COVID here. Now we can see all the variants which started from alpha, and they are struggling in the environment, and then you get a more virulent strain, beta, then the gamma, and so on and so forth in different parts of the world. And now we have the Omicron, and then, of course, the lineage of Omicron, which are the subvariants, BA10, BA5, and BA10 point blah, blah, blah. And these are the variants which actually survive, talking about survival of the fittest. These are the fittest variants which survive. So I'm not going into too much virology, but this is just to show you that how this has been spreading over the years, the last 3 to 4 years. And of course, as I mentioned earlier, the SARS is such a virulent virus, and it spreads even if we are talking to each other, and that's why we have to do the social precautions and various types of masks and various types of precautions, hand washing, and so on. Now, actually, I am a virologist as well, as you saw, and we were told that the viruses will not survive on hard surfaces for some time, and that was the conventional wisdom of virology. But actually, this SARS-CoV-2, which is the etiological agent of COVID-19, has disproven that and shown that they can survive on surfaces for up to periods of 2 to 3 days, even without any humid environment. So this is the so-called fomite spread from contaminated surfaces. And we as dentists have to be doubly careful because of these things. And I'm sure all of you are very well versed in this knowledge of viral spread. So now we have, as in terms of SARS spread, 5 different phases of transmission. I have put it in brackets and dentistry. Now, what are these phases? Why is it spreading so fast? And why we have to take precautions? So we get asymptomatic phase, which is the transmission from a symptomless carrier. So this is the very initial first 1 to 2 days. Usually it has an incubation period of about 5 days. So symptomless carriers, they can walk into the clinic anytime and they'll be perfectly healthy, and you will not know that they are spreading the virus as we are using our air rotors and various other instrumentation in the oral cavity. Then we had the pre-symptomatic or the prodromal phase. And these are the guys who will maybe have a fever with cough and sniffles and so on. Of course, if these guys walk into your clinic, they will know that you are he may have a common cold, or it could be something like SARS-CoV-2. Then this is a pre-symptomatic, it's a prodromal. And then after 4 to 5 days, he gets the real symptoms. And this is an acute phase. Sometimes he'll be having very high fever, and then, lethargic and weak and so on and so forth. So this is obvious phase, and these people will not walk into your clinic. Then we have a post-acute phase, which is a transmission from a recovered carrier. And you may not, know about this. Recovered carriers, although they may be, PCR negative to some extent, they may have very small quantities of viral particles in the oral cavity, and that's they too can walk into your clinic after recovery and then spread the disease. And lastly, we have got transmission from fomites. You are touching things, patients' hands or whatever they touch may spread the infection. So these are kind of a exploded form of how transmission happens in dentistry. Okay, so this just to give you some of the historical aspects. And so let's go into post-pandemics and dentistry. Now, during my lifetime, I'm over 70 years old now, we have had number of these epidemics and pandemics, and these have actually impacted our dentistry, the practice of dentistry, and how we teach our students the dental education as well. So let me go through very few of these, some of these which actually happened during our lifetime. Hepatitis B was not a pandemic, but it is a kind of epidemic, and also it is endemic, hepatitis B, which is also hepatitis C. And then we had the HIV/AIDS pandemic in 1981, which started, and then it's now endemic in all over the world. Then, as I said, 2003 we had the SARS infection, and 2019 we had COVID. So these 4 pandemics and epidemics have actually molded how we practice dentistry. And on the right, you can see, I collect all these articles from the Time magazine. This is how it has affected us. Okay, so in terms of, in very short, I mean, these pandemics and epidemics has impacted dental education and dental practice for a long time. So actually, previously, as we all know, when I was a dental student in 1970s, we did not practice dentistry with gloved hands. We had, it was, I can remember still there's saliva on our hands and sometimes blood, depending on when you are doing oral surgical extractions. And we did not really, we paid casual attention to this, and we washed our hands thoroughly. But then 1978, because of all these hepatitis B and various things which started earlier, we started in 1970s, the CDC developed universal precautions. Then with the advent of HIV, we had standard precautions in 1980s. Then finally, in 2003, we added some more further precautions, and these were called transmission-based precautions, on top another layer on standard precautions. This is to prevent spread of infection through air and through blood and body fluids. And also these were previously mainly based for hospital-acquired infections and hospital infections, such as vancomycin-resistant Staph aureus and so on and so forth. But I don't want to go into details there. So this current transmission-based precautions, which we in dentistry have to apply, was a direct effect of the pandemic of currently COVID-19 pandemic. So very, very briefly, let's talk about what did we do because of that. Then there were, as an educator and as a dean and an administrator, our post-pandemic dental education was totally impacted by this. And I don't have to tell you because you all are experts in that area, some of these areas. There were a lot of educational imperatives. We had to, I was speaking at a meeting in Southeast Asian Association of Dental Educators, and I gave a 1-hour lecture on how our COVID-19 has impacted dental educations. And also our current educators, students have to be taught how they have to be prepared for future pandemics. And again, within a half an hour, I cannot discuss this, but then maybe at different occasions, we can discuss these. But again, what I want to tell you something is, which is very interesting, is that because one very important thing, because we have now, because of the COVID, we can have an expanded repertoire of dentistry, which is now, for example, we in the UK government allowed dentists to be vaccinators. We are allowed to do vaccines as dentists. So they actually made changes to the law for health professionals who do not work with medicines to become vaccinators for seasonal influenza and COVID-19, and this included dentists. But of course, then we have to be aware of what we are doing, and we have to have an appropriate insurance cover, and we have to be competent in delivering these vaccines. But of course, we deliver all these local anesthesia day in and day out, and I can't see any reason why we cannot do vaccines, which are very simple once you know what to do. But of course, the precautions have to be taken at a later stage. So I just wanted to give you one aspect of a very, very small area where dentistry has been impacted by the COVID-19. So again, in this this review, which I wrote to JADA, I mentioned that COVID is becoming an endemic disease, and particularly due to the SARS-CoV-2 variants. So what should be the strategy of the dental community? And in this context, I put up this post-pandemic dentistry strategy, which is, I just very quickly go through this in the next few minutes. Point of care diagnostics, teledentistry, infection control, which entails two major aspects: engineering controls and administrative controls. And fourthly, continuing education and pedagogy, which has been impacted and which is going to impact in post-pandemic dentistry. And last but not the least, COVID-19 vaccines and vaccinations. So let me take these vaccines and vaccinations next. And we can see there are so many variants coming up, and we have to have vaccines for this. And newer vaccines are coming up, bivalent vaccines and trivalent vaccines, for which is suitable for various variants will come up. And this is going to be like, as I will show you in a moment, like influenza vaccines, which we as dentists have to take. Now, the vaccines, again, just very quickly to show you, are very, very effective, 95% effective. And we, nobody virtually gets killed unless they have underlying comorbidity. Vaccines are proper, any kind of vaccines, you know, you're talking about vaccines made in China or any other part of the world, which have been approved by these authorities in respective countries, are very, very effective, and they can be, people will actually not get severe disease or death due to that. So it's very, vaccines are the way to go. And currently, 9 major COVID vaccines are available all over the world. And the current, if you have the pandemic, it is the pandemic of unvaccinated. And that's what's happening in China now. They are very scared to open up because only 60% over, 65% over 60-year-olds have got the 3 shots of the vaccine. So if now they open up, there's going to be a huge death rate in China. So this is why they are triply cautious, doubly cautious about opening up and still maintaining the zero COVID policy, but they seem to be relenting a little. Being in Hong Kong, I know this situation very well, and these are some. This is some of the one of the. So it is the pandemic of the unvaccinated. So I will come back to this next third point. CDC stated that oral health care workers must be vaccinated against several occupationally transmitted infections. Or therefore, vaccine against COVID-19 is likely to be a new entrant to the list of vaccines for dentistry. Now, I give CDC as a major example because a lot of other countries, including Europe, Hong Kong, and various other parts, actually follow these guidelines because they have got the wherewithal, and there's a lot backed up by a lot of data, and this is sort of the gold index through which everybody works. Now, vaccines for the dental team, I'm just plugging my book here, Essential Microbiology Dentistry, which is now used all over the world. I'm just currently doing the 6th edition of it. And in that, we say that these are the vaccines which should be given to dentists and dental care workers, which is hepatitis B vaccine, so-called MMR, measles, mumps, rubella vaccine, and chickenpox vaccine for shingles if people are non-immune, then BCG vaccine, then DTP, which is tetanus, polio, diphtheria, and the seasonal flu vaccine, which is the annual vaccine, which we have to take as dental healthcare workers. Now, to this list of 6 vaccines, we have to add COVID-19. However, it is optional in some countries. But I think that is a short-sighted policy because if you are not properly vaccinated, you will end up in grief, and you may even get severe disease. And then the aftermath of this COVID, nobody can predict. And I was speaking with Dr. Jeff just before the meeting from US, Vienna in USA, and he was telling I mean, this is a neglected area of COVID in the sense of post-COVID patients. Some of them end up with long COVID and different after effects. So nobody really knows if you're not properly vaccinated. If you get the full-blown COVID, then that is where you have this long COVID and all this the aftermath of this nasty infection. So although it's optional in some countries, I think we should all get it. And then in the future, there's going to be a combined bivalent vaccines or trivalent vaccines. They call the COVID flu vaccines, or they call it the co-flu vaccine. So that means the number of vaccines which we have to annually take will be reduced because instead of 2, you can take 1. Now, all these at the top, I mean, these are some of the vaccines which you don't have to take recurrently if you are properly covered by these. Now, the good news in this context is that oral vaccines are coming along there are 2 or 3 vaccines which have been, you can see I'm not hoping that you can read this because just quickly go through all these people in United States, mostly in United States, I think they are in phase 2 trials. Some of these are oral vaccines. It's like the polio oral vaccine, which you add some of the so-called Sabin and Salk vaccine, some of the so-called the Salk vaccine, you put 2 or 3 drops onto ask the patient or kid to open the mouth, and then these organisms, these are not the real, the very powerful, virulent organisms, but these can take hold of in your mouth. They can grow in the mouth, but will not cause disease and produce antibodies. So the oral vaccines are coming along, which is very good because you don't have to get jabs. Then you have the nasal spray vaccines are also coming along, and that is also a positive development. And within, I think, next 2 to 3 years, we will see some of these vaccines coming into common use. So this is in terms of the post-COVID things we are seeing. So other things which I showed you, those four balloons, which are post-pandemic dentistry. The other thing which we have to educate ourselves, if you are practicing dentistry in any part of the world, is how we can optimize the use of teledentistry. Now, teledentistry, sometimes people think it's just speaking to the patients. No, it has so many different divergent uses of it. I'm just giving you some here: teleconsultation, telediagnosis, teletriage, telemonitoring. And now, together with the AI and all the other digital developments in technology, you can do remote consultations, which actually quite useful because patients don't have to come to clinic unless they are absolutely necessary. And this is useful for people who are in developing parts of the world. Let's say take a place like Indonesia, which have hundreds of or maybe hundreds of islands throughout the archipelago, and this will come in very useful, the teledentistry in the future. And I made a point when I made my presentation on modern education and COVID, that teledentistry is something which we should include in our syllabuses and curriculum for for the Z generation of students. And for them, it will be nothing because they are very, very conversant with this new technology, not like old folks like us. We have to make a struggle to start something new, And so teledentistry is very, very important. So, as I say, it's useful for remote consultations, follow-up advice, pre-symptomatic exposure period. If they cannot walk out of their room, then they can then talk to the dentist about it or whoever it is. Post-recovery period, post-treatment period. And also, you can, during that period, because one of the biggest, issues in COVID just now is the so-called collateral damage, which we have done because over the last 3 to 4 years, other oral diseases have been neglected for one reason or another. And so if you're having teledentistry, people can show you what has happened in the mouth, development of cancers, or whether they are regressing or progressing, and follow up for suspect oral lesions, and so on and so forth. So teledentistry is going to be very, very, very important. So we have covered vaccines and teledentistry. I'm not going to go into point of care diagnostics, because diagnostics are now becoming so routine with rat test and PCR tests and so on and so forth. Let me just lastly take on the last few minutes the infection control with regard to two major aspects: administrative controls and engineering controls. Now, engineering controls are controls which actually which you cannot implement yourself unless it has been done by the authorities in the hospital or the clinic. It's in terms of negative pressure ventilation, in terms of UV radiation, overnight UV radiation to kill the fomites on the surfaces and disinfect surfaces, in terms of creating space for people to come in and not to have proper social distancing in the clinics, and so on and so forth. So infection engineering controls are very, very important in preparing, particularly for future pandemics. And for example, these open clinics in dental schools where you have 40 to 50 chairs or even more is not going to gel in terms of future pandemic control. So if you're having a multi chair clinic, it has to be very important. They have to be separated in terms of, because you have to have provisions for infection control in the case of, I'm hoping that nothing will happen. But in any case, it is very good to have these very hygienic clinics which are separate from one another. So the administrative controls are the ones which are the infection control guidelines. And so the hierarchy of controls in regards to infection control, which is shown in this diagram, is again, again, we have the engineering controls and the administrative controls. The least effective, the most effective are in blue here. The elimination of the pathogen is the removes or prevents entry of the pathogen. That means if you can prevent the patient coming into the clinic through teledentistry or any other means, that's the best way to avoid infection. Then once you come into the clinic, the design of the clinic and opportunity of exposures and your air control systems, negative pressure ventilation, social distancing, COVID tests, etc., are all important. Then the policies and procedures are the administrative controls. And lastly, we have personal protective equipment. So, so all these can be combined with the standard precautions and transmission-based precautions, which you see on the right side of your screen here. So these are the controls which I mentioned earlier in the last ones: elimination, engineering, administrative controls, and PPE. And so that's what you got here. And then standard precaution. And when you combine these two together, so there's a framework for COVID-19 control in dental practice, which is planning and protocols, patient screening, preparing facilities, PPE infection control, and aerosol control, which is critical. So again, this is a very, very short lecture, and I don't have to go into time for this. You can talk for 2 hours on this aspect. So post-pandemic dentistry, COVID is here to stay. So let me share with you some of the predictions by experts. There's a fantastic article by Christopher Murray, and he says COVID-19 will continue, but the end of the pandemic is near. This was published in Lancet a few months ago. And this Christopher Murray is from the Institute for Health Metrics and Evaluation. So in that particular article, he has mentioned 5 key points, which are some take-home points for some of you. So And these are very, very startling statistics because these guys collect statistics from all of the world. So on a daily basis, you have 120 million Omicron infections a day in the world. So just look at this. This was a few months ago. It may be more now, possibly could be less, but essentially just gives you a sense of the spread of this virulent virus from starting from Wuhan, China. And then we have the current wave is 10 times the peak of the Delta wave of April 2021, because the Omicron variant and the subvariants are the most highly infectious variants of the virus. So you will be surprised by this statistic. Approximately 50% of the world is infected with Omicron between November 21 and March 22. So this is about six months period. But one way or the other, you are going to get it. It's like the common cold. So I call common cold 2. So it's actually less effective than the less symptomatic than common cold sometimes, you know. And then this is very important as dentists. We have to remember that 4 in 10 persons who walk into your clinic may be asymptomatic carriers of the virus. So this is why it is very, very important that we continue to take care in terms of infection control and also do teledentistry and all these other things. So, and also this is also something which is important, because if you are vaccinated, the death toll from Omicron is similar in most countries to the level of a bad influenza season in the Northern Hemisphere. So people didn't know this, or people didn't care about it. Every year, millions die of influenza because some of these guys do not take the vaccine. But now we have a similar situation. Omicron variant is killing. The death rate seems to be similar. So COVID is here to stay. This last concluding slide. It continues as a pandemic form, surging and up and down in some parts of the world, and it is always present but transmitted among people at modest, predictable rates until the world reaches the herd immunity. Now, this herd immunity, as you will see in the next slide, that concept also has been changed. So the current estimates are 90% should be triple vaccinated for herd immunity. Now, I don't know whether herd immunity, so-called herd immunity, which we are talking about, with all these people vaccinated, could be true, or whether it's practical to do this in different parts of the world, because if one part of the world is not properly vaccinated, then there's continuing infection and endemicity. Why? So my last slide here is herd immunity a myth? So the current influenza, which is circulating in the Northern Hemisphere and the Southern Hemisphere, actually started in 1918 influenza pandemic, where more than 100 million people died because at that time there were no vaccines. Now it's circulating even 104 years later in various mutated strains. That's why we had to prepare a vaccine for each year for the particular variant which is circulating for each season, either in the Northern Hemisphere or the Southern Hemisphere. Some of you may not know, if you are taking the vaccine, which is this year, let's say if you take the vaccine in UK or Romania, that vaccine for influenza may not work in Hong Kong, because there are different variants of vaccines, influenza, floating around. So as I said, these influenza infections since 1918 has descended from the same strain. So ladies and gentlemen, this is my last slide. And I would like to thank Professor Marion for the kind invitation and for you participating in this particular conference, and all of you eminent speakers. And I look forward to listening to some of your presentation. It's quite late here in the night. Maybe I will have to look through the YouTube. Thank you very much. Thank you very much.